to be here with you today. And I know people will be joining as we start, so I want to use this time as much as possible. I typically do and have done this in a full day session working with campuses across the province, so there's only so much we can say in 1 hour, so I want to use as much of this time as possible. I'll tell you just a really brief update about myself, just so you can situate sort of my work and experience in this work. I have a master's in psychology and a master's in counseling psychology and a PhD in educational psychology. So I began my career a long time ago working with adolescents in custody and detention centers and group homes and foster homes in a clinical capacity, and then moved into the Center for Addiction and Mental Health for evaluation purposes as an evaluator and a researcher. I'm an assistant professor at Western as well, and I've had the opportunity in the last 15 years to work with the education sector in developing and implementing and evaluating mental health and healthy relationships programming across the province and across Canada, and within CAMH more recently have been working with the Youth Wellness Hubs initiatives, which is very similar to what campuses are trying to do, but just in a much larger scale in terms of integrating all mental health services into one Youth Wellness Hub that's co-located and it's accessible and it's a single point of access. And so my work there really kind of dovetails into my work in the education sector. I was also the mental health strategist for Western University, which for a couple of years I worked very closely with their health and mental health systems and everyone across the campus to really understand the needs of students and to develop that implementation strategy for them to work on. And with CICMH, I've been an evaluator coach with different campuses across the province, helping sites think through how to evaluate their different health and mental health services. And for the last year, I've been working with Durham College, so I don't know if any of my colleagues from Durham are on, but they have been in the last year implementing a new service delivery model, and that's a clinical triage model. So going from the traditional, wait list, appointment-based, fragmented system across campus, they have been working really hard to implement this new model. So we've been working closely together to help them do that, and they have been very successful so far, but I'm going to share a lot of the lessons learned with you as we start to think through a new delivery model. So we're going to go through all those pieces today and really some considerations about how to build a new model on your campus, and it's going to force us all to really dig deep into what we have and to understand that there are tight physical, administrative, academic structures and policies and funding challenges and even philosophical differences on campus that really prevent us from delivering service in the most efficient and effective way. But no matter our training or our department or our role on campus, we know that we can deliver service more efficiently and effectively to young people, and that we ultimately have that responsibility. Campuses are, predominantly academic institutions, and their job is to provide, excellence in education for our leaders of tomorrow and our students who are going to go on and thrive. But as an academic institution, we also know that if we don't support their mental health and well-being, they can't thrive and they can't be successful leaders of tomorrow, especially in this rapidly evolving world that we live in. So this is important for all stakeholders, and I can probably guess that the most people who have signed on for this webinar are the service providers, are the mental health and wellness people on campus, but it really is an academic consideration for every stakeholder on campus to be a part of this. So that's what I hope we're going to talk about today. I'm going to tell you that, campuses across this province are really doing some amazing things with providing knowledge and skills to young people and addressing their mental health and well-being. But every campus that I've talked to and worked with has really very similar problems. The first is that we have a lot more students attending post-secondary education than we ever have. And because of this, our demand for services has absolutely increased, and the number of young people accessing services have increased. Clinicians will tell you that the complexity of the presenting problems of students is just that much more complex and significant. The stress and the anxiety and the pressure and the relationship and being away from home at a younger age, exposure to all the things that we see online and offline. This has just meant the complexity of the issues that clinicians are dealing with that much more significant. We also, across campuses, have multiple access points for care. And so the one thing that students will tell you, and that have told me, is that I don't know where to go to access help on campus. They can go to residents, they can go to health services, they can go to mental health services, they can go within their faculty. And when you have multiple access points of care, you have young people accessing cares in different ways, telling their stories multiple times, service providers likely not connected with one another, and that's a fragmented approach to service, which leads to inefficiencies in the system. It's what we see in the community, and it's also what we see in a smaller community on campus. And the other thing that we hear very clearly is that service and service providers are often working in silos. So, you know, the health folks don't always know what the mental health folks are doing. There's not always shared electronic records across all service providers on campus. And this fragmentation, as you know, it provides frustration for both students and the service providers working in the system, but it also leads to a lot of inefficiencies in the system. And most importantly, the impact on staff is very significant. We know that there's a tremendous amount of burnout among our service and staff on campuses because it's very difficult work. There are wait lists, and there are students who need help for longer than our brief sessions can often provide. And so there is this push and this, you know, really real need to really address the increasing demand of mental health services on campus. And we typically have done this in a number of ways. Traditionally, we have what is called, you know, wait lists. So, you know, this is the common strategy that everybody uses. We essentially, you know, until all therapy and available counseling slots have been filled, you then put every student on a wait list. And services are often provided on a first-come, first-served basis for the most part. We are not looking at the severity of symptoms necessarily. And the waitlist approach, you know, we tend to lose students along the way. We tend to see a lot of no-shows for initial appointments because sometimes, you know, they need help right in that moment. And if we can't give them help in that moment, sometimes that crisis resolves itself, or sometimes they just don't want to be part of it and they just kind of give up. So the waitlist, you know, while it serves a purpose in the traditional model, it's not the best for meeting the increasing demand for mental health services. A second option that what we see on campus is that every student gets services on a brief, limited basis. For example, some campuses are doing, you know, everyone gets 3 sessions, regardless of sort of the expectation that they need more. That's all every student is going to get. And this has some benefits to it because at least everyone is receiving some sort of service at the center and some assistance. However, if you're going to refer students out into the community, you don't always know if they get there, and most students sometimes need more than 3 sessions. There's some universities in college campuses that have instituted a third option where staff maintain their own caseload, and there's an expectation that staffs would be seeing a certain amount of clients each week, and there's some sort of flexibility in how and when they see them, but, you know, students would be seen every couple of weeks. Again, this doesn't really help our increasing demand for mental health services. We tend to actually have more and more students on wait lists and waiting to be seen, even though if this allows clinicians to manage their own caseload, it's problematic because you do end up getting burned out. I mean, ultimately, that's what happens in many of these cases. So what we have seen forever in physical health in hospitals is now really moving in the mental health system. And to me, this is a transformation, and it's not an easy transformation to embrace. Our mental health organizations in the community are struggling, but they know they need to do that, and that's really the implementation of clinical triage system. Clinical triage system originated, I believe, in military time when they needed to decide, you know, which soldiers to get better quicker. Were they going to look at those that had the worst injuries and get them better so that they can get them back on the battlefield, or were they going to look at those who had the easiest injuries to fix and then they could get out quicker, perhaps? So it has its place in the medical decision making, and it has been used in health systems, and it's new and it's novel to the mental health system for lots of really good reasons. So what are we to do as adults in the lives of young people on campus? We know we need to do something different, and we know it's about changing the system so that everyone can fit in a way that doesn't result in staff burnout, that uses our resources efficiently, where students don't feel confused and frustrated about what to access on campus. And that really is implementing a clinical triage model. And lots of places are starting to do this. I want to say that Memorial University was likely probably the first one because of their step care leadership and step care delivery of services, but I'm not quite sure which is the first campus. And maybe when we have our questioning, there'll be people who have started to do this as well. So really, what is a clinical triage? It at the very basic level, it is just this rapid assessment of students into levels of care or service based on their presentation of acuity of needs. And so what it typically involves is that, a mental health provider, although that varies who that person is, will rapidly assess students using a triage tool to, in the moment, that's their first appointment, in the moment, to ascertain whether they need to see somebody right away because they're emergent, whether they need to see someone within 24 or 72 hours because they're urgent, or whether they could actually wait and see a service provider a week or 2 weeks, or whether they're not even appropriate for that service and that they actually need to be seen in the community or somewhere else. And so what ends up happening is a mental health provider will determine that scheduling of an appointment or a referral to external resources. And so it's a real shift for students because typically when students are booked into an initial appointment for services on campus, they're expecting that 1 hour with a service provider and a mental health provider who's going to help them with whatever it is their needs. But in a clinical triage model, you need to rapidly assess in about 15 to 30 minutes what is going on with that young person, what's their history of suicide, what's their history of addictions and mental health, and what service provider can best fit their needs right now if they are presenting with immediate needs to be presented. So if you're developing a clinical triage model, you absolutely have to have in your model a walk-in model or availability of spots right on the spot that young people can actually access care. And that's very different from a traditional model because typically we are booking appointments and we don't always have open time slots for service providers to see somebody on the spot. And what a clinical triage model does is that students who have those most pressing concerns can be seen right away and the rest are seen later. And we'll talk about some of the benefits and disadvantages to that because lots of people who have started with the clinical triage model on campus have said, well, it works really well for students with really acute concerns and really high-risk needs, but I'm worried that those in the middle and those at the end are not getting the services that we think they should get, in the time that they should get. So there are advantages and disadvantages to the model, and there are more than one way to develop the model that best suits the context in which you're working in and the academic structures that you're working in. So I want to think about what we strive for in developing a new service delivery model that has a clinical triage system in place. So I'm going to say this because I believe in it, but I know that it's not always possible on campus. The first is co-location or centralization and integration of health and mental health services on campus. My dream is that every campus in this province has a building where everybody who's involved in the health and mental health and wellness and learning and all of those services are together and centralized. This would reduce barriers for young people accessing help. It would improve collaboration and communication among service providers because now you are integrated and you are delivering service in one place and you develop deep familiarity with the student because you're all kind of talking and working and they can access service in a more efficient, effective manner. And a triage system doesn't necessarily need co-location and integration of these services. You can triage at multiple spots on campus. If you do that, it doesn't necessarily reduce the confusion that students might face, and you might not get the reliable, consistent screening across campus that you want to have in a triage model so that everybody is receiving that assessment in the same way and then being scheduled to different providers. Like there is confusion when you have, multiple sites on campus doing the triaging. It's not impossible, but I think there's an added complexity. The other piece is that, in a clinical triage system, aligned with the co-location and centralization, a single point of access and assessment is ideal so that young people know that this is the triage place. I come here for 15, 30 minutes, and then I get my scheduling of appointment or I see somebody right away. The other thing is that we strive for timely, convenient, accessible, equitable, efficient, and effective services. All things that we try to do every single day in the work that we do. Convenient, the one thing we hear from students is, oh, all these programs and all these services are offered when I'm in class, and there's hardly anything happening at nighttime when I need help. So thinking about in our triage model, if we're transforming our systems, we need to think about those hours that are accessible and convenient for students, and that are equitable and that meet the needs of all young people. And so if you have the luxury of being able to build a space or redesign a space on campus for this purpose, having it redesigned by the students and having them pick the color and be student driven and them pick the furniture and then them pick the artwork, that is what we strive for in being able to deliver that service for young people in the best possible way. So of course there are potential advantages in building this clinical triage on campus that I have seen, that the literature has written about, that campuses are starting to really realize. The first is that there is going to be greater collaboration between your service providers. So in my work with Durham College, I've had the mental health nurses say, like, wow, I finally understand now what the wellness coaches do. And I finally understand the work of the different wellness and therapists on campus actually do, because now they're working together. And that's a really, really important part of this model, because that collaboration is going to hopefully result in more efficiency of the services. The other thing that's important in a triage model is that it's a mental health provider typically doing that assessment, 15 to 30 minutes, although it doesn't always have to be, about student need, rather than somebody at a front desk who is working in an administrative role. Because sometimes that does happen to somebody at the front desk. Somebody comes in crisis and they have to figure out what to do with this young person. And the triage model really wants to have a mental health provider be able to do that assessment so that they can determine the level of acuity in the most efficient ways. Another advantage to this model is that all acute cases are going to be responded to rapidly and brought to a clinician, because that is how the model works. If you're assessed as needing care right away, you will be seeing a clinician right away. That means as administrators, if you've got a scheduling people to have open spots so that you can have that. And you will be able to recognize acuity at a better rate by having standardized tools in place, and there are lots of them that exist, to be able to implement this model more effectively. Wait times for initial appointments in the literature tends to decrease, especially for those in greatest distress. So what we see is that, so we do have significant wait times, obviously, on campus, but for those who are in greatest distress, because they're being seen right away, we absolutely see wait times decrease. And we also see our initial no-show appointments for first appointment decrease, which is a really good significant marker, because a lot of times when you are booking somebody into a week or 2 weeks, you tend to sometimes get a no-show. And a no-show means that the clinician now has a 1 hour where nobody showed up, and that's 1 hour of service lost. And what a triage model actually shows is that you can decrease those no-shows, because those people who need the help are getting it right away. And even those who are in the moderate range are getting help within 72 hours. And so people are coming when they actually need it. We can help in a triage model screen out student concerns best served elsewhere. We know that not everybody needs to see a psychiatrist, and that sometimes those crises in the moment certainly just need the 15 to 30-minute talk with a mental health provider to kind of, settle and re-understand what's going on, and perhaps provide them resources that they need, and they'll be okay. And that's really useful, because those students would have been booked into a 1 hour slot with somebody who could have used that 1 hour slot for more emergent or urgent concerns. Now, you can often see 3 students in 1 hour versus just 1 student. And this has to do with the fact that that first appointment is a 15 to 30-minute assessment. And typically, that first appointment is an hour assessment in most traditional models. So in 15 to 30 minutes, you potentially can see up to 3 people in a triage model where they're screened and their level of acuity is determined, and they're either seen right away or they're booked in later. Whereas in the traditional model, it's typically 1 hour and you're seeing 1 person for 1 hour. My favorite part of clinical triage models on campus and in the community is that they are really walk-in models of care. So walk-in models, the research is very strongly associated with this, is that if you have a walk-in model of approach, when young people are ready to come and get help and access help voluntarily, they're at a stage of readiness where they're going to get better because they're ready to get better. And if you can provide services to them in that moment, we see more effective outcomes for young people. And that's a really important part of the triage model because you have to have those slots available for young people. And a triage is oftentimes described as a window of opportunity, because those windows of opportunity is when a young person is really feeling like, I need help, and they're able to be given help in that moment. And step care model is an important part of triage because right now, you're not going to be able to see everybody on the spot. You can't have all these walk-in open slots open. But a step care model says that those with the highest needs are going to get high-intensity services. Those with the lowest needs are going to get a variety of low-intensity services, and you go up in the steps depending on the intensity of student risk or need. And that tells you that you have to assess student risk or need reliably and consistently with tools that allow you to do that, which again is a shift for many campuses because not everybody's doing that, and sometimes people are just assessing risk and need in clinical interviewing. And although clinical interviewing does do that, it doesn't do that necessarily in a reliable way. So the same day access for care for virtually all students is really an important component of this model, and being able to have a variety of interventions along the spectrum of care is also really important in this model. So of course, there are potential disadvantages to implementing this system. I'm going to tell you right now, it's not going to decrease the number of students accessing service. In fact, what the research and what experience tells us is we actually have increased access to service. We do have more client flow, believe it or not. But over time, we get better and more efficient at being able to deal with the increasing number of students coming forth in receiving services. So initially, it's going to feel like it's an extra burden on the system, but it does settle itself out. There's going to be an increase in overall acuity within the department, which means that you are going to see students with more stress right away, and sometimes that can be very stressful for the department in dealing with that. Another thing, and I can tell you that to get the buy-in for a model like this campus-wide takes at least a year, if not 2 years, in my experience, because this is really a shift in how people work. It's a shift in how students perceive the work and perceive the service. And the communication and education that you're going to have to do across campus is going to be significant because people don't like change. And it is going to be a different way of working, but it is going to improve. It's going to improve everybody's service, the satisfaction with the service. It's going to improve client outcomes because we have tons of evidence to show that if you implement this model, it will be better for staff. It will be better for the campus community. There is a burden on triage appointments because not all service providers are part of the triage team. So if you are booking people in to see somebody right away, they're often dealing with the most acute cases. So oftentimes there are not, if you have a big department, not everybody's part of that triage team on that given day. So the burden is not always shared by all. So I've heard this a lot, and it's tricky to know when screening ends and when assessment begins. I understand that. But some clinicians do not feel comfortable making a risk decision in a short meeting. And screeners are designed to be red flags. So they're not designed to be diagnostic in nature. So you're not supposed to be able to figure out exactly what's going on with the person and know the intervention, but you are supposed to know that something is going wrong. And in 15 to 30 minutes with the right tool, you absolutely can figure that out. And you can develop a system and your comfort level around some of those guidelines when young people come in with certain, profiles about how you would determine their risk. But again, we've heard from lots of people, and even some of our, mental health nurses across campus, they don't feel comfortable making that decision about a young person's risk in such a short period of time. Inherent in this triage system is the story is told more than once. So we are trying to take away that experience of young people who have to go to multiple service providers and share their story with multiple people. But don't think that the triage system is going to take that away. It still happens. Because you're telling your story to the triage person in your first initial appointment, and then when you're booked in to see a service provider, you're going to have to tell it again. But it's only 2 times necessarily, then it could be 3, 4, 5 times. When we refer students out at the triage level because they don't need to actually be seen by a therapist or a counselor on campus, are they going to follow up with community or campus resources? Do we feel comfortable sending them away when they really need somebody in the moment? And they think they need somebody in the moment, but we refer them out, and whose responsibility is it to follow up? Or do we have a responsibility at all? Is another sort of potential disadvantage to think about so that we can mitigate those. And finally, I think demand will always exceed supply. So with this increasing demand, I don't think any university has seen a corresponding increasing in resources, financial or people-wise. In fact, it's often a shrinking budget and a shrinking amount of people having to do more work. So we have to be more creative and more strategic in the way we do things, and this model is one of those ways to do that. So if you're thinking about transitioning to a new clinical triage system, and you're thinking, oh my goodness, where do I start? When I work with campuses, I ask them to think about their why. You really have to think about why you want to do this, because you're going to have to communicate this why so often and articulate it so much to people, because nobody likes change. And especially service providers will feel very uncomfortable with this model because it's not the same way that they have been delivering service for a long time. So developing and communicating and educating people about the why is important for buy-in, as you know. It's important to convince faculty members, for example, on campus, that this is the new model, because they're often, they talk to students and students will go to them, and they need to understand how this model works, what this assessment is and what it is not, what that initial first appointment looks like and what it doesn't look like. And oftentimes, we need to think about who's going to be responsible for this ongoing communication and education of the community, because it really is an ongoing commitment. And I feel like it could really stall things if this isn't thought about at the very beginning. It's not just about posting it on the website. It's about going to every single meeting administratively and otherwise and sharing this new model and telling people what it's like over and over and over again, because ultimately people forget. And students in particular need a really good understanding of now what that new experience is going to be. So think about that why, because that is going to be woven throughout the entire model development. So the second thing I want you to think about if you're moving towards a clinical triage model is really what that triage team is going to look like. And you might say, I only have 4 service providers anyways on campus, because some of you are very small. So every staff member is part of the triage team. But some universities have, a complement of 30 to 40 between health services and mental health services and learning services that are all together in this wellness kind of approach. So it really depends on what your campus culture is like. And over time, we have come to see some certain characteristics of what makes a triage team better than some other characteristics. And if you have the flexibility to think about who could be on your triage team, it's important to understand some of these characteristics. So the first is that they're also known as a jack of all trades. So the triage team is going to manage that initial triage when somebody comes in. They might deal with walk-ins, they might deal with crises, and they might deal with referrals. So they really have a lot. That front desk person who's doing that assessment, or If you have triage clinicians doing the assessments in their room, they really need to kind of deal with all of those things at once. The other thing is not everybody on the team actually wants to be part of the triage team. So always assessing interest and willingness and knowing that some people may not be ready to embrace this type of work and that they will come when they're ready to come, and always work with those who are actually willing and interested first, and that it's no wrongdoing if somebody is not ready to be in that role. There has to be an ability and a comfort to conduct brief assessments and make decisions on the level of need and risk. And that is really, it can be determined in a number of ways. They can tell you they feel comfortable, because I've had clinicians say, I don't feel comfortable. You can assess it through their work, or just have a discussion with your team about who feels most comfortable in doing this. And sometimes it's a work in progress. So, for example, in Durham College, when they started using their intake tool, it was taking 45 minutes for them to get through what should be, a 15 to 20-minute discussion. But now they've gotten much better at it. They're better able to assess risk. They're better able to make the decision based on that tool. So it does take time to do those things quickly and efficiently. So being able to assess who can do that is important. The triage team also needs a lot of familiarity with the college or the university's community and its system, because if you're doing some of that referring out in that initial appointment or offering them services elsewhere, you need to kind of know what's happening there. And also in the community. And I mean, as a jack of all trades, they're going to be involved in prevention, intervention, and post-intervention work because the triage team is going to be dealing with all of those pieces. So where does the triage team sit and conduct initial assessment? This is something that sites struggle with, but physical space has both physical meaning, and I think it has emotional meaning for people, because everybody wants a space where young people are going to feel comfortable and safe, and it's central. But no university or college campus often has this in place. There are some that have ridiculous, beautiful places, but there are lots that don't. And there's a feeling sometimes among service providers that if you don't take care of my space, administrators, if you don't find us good space, then you don't really believe in this work. So if there are administrators on this, or if you can communicate that, it is a really, really important understanding to find that physical space that's going to work. Because where are they going to conduct the assessment? And do you have a private room where this 15 to 30-minute assessment can take place? It can't really be done out in the open waiting room for the most part. Now, some people do an assessment self-report. So the young person in the waiting room will complete most of the assessment in self-report, and then they still meet with somebody to go through that so that risk can be determined. So it doesn't always have to be done in clinical interview. And believe it or not, some places I know in the U.S. do this all the time. They do telephone triage. So you call in, and they assess your risk on the phone. So the initial triage appointment. So at the heart of any clinical triage system that you want to put in place on campus, it's this 15 to 30-minute, give or take 5 or 10 minutes, immediately available to students. And as I mentioned before, it can be a walk-in, where young people walk in and they are seen in that triage appointment, or you can do some telephone. There has to be a triage protocol developed in place, and there are lots that exist that includes prioritization criteria. So if a young person is screened high-risk suicide, what is the protocol in place? Everybody is going to have already a protocol in place, but what if they screen high-risk on substances? Or a loss of their family member, crises, anxiety. What's the triage protocol? And how are you going to define emergent and urgent and, routine kind of care? And what are the response time targets? So you kind of have to get down to, within 24 to 48 hours, this is how we're going to deal with this situation. Or we're going to book people in whenever we have an appointment. So the type of contact and the corresponding response times are really critical here. So there are tools that exist, and you're going to probably have to refine them for your particular context and especially what your service providers feel comfortable with. But the initial triage assessment, you got to know who the student is and what led them to their services. So what's going on with them, and a number of ways to assess substance use, medication, medical concerns, have they had any history of hospitalization, because all those pieces are going to help you kind of assess the severity and acuity of presentation as well as some of their risks. And then, conversation about what those next steps would be. Now, I've outlined them as emergency, urgent, routine, and referred, but other universities have used, in campuses, have used other kind of terminology about who's seen right away by a clinician, where somebody is seen within 24 to 72 hours, and what they consider just, standard level of care. Again, it's best to tie these criteria to the overall mission and philosophy of how you want to operate and what that messaging and communication is to young people and the stakeholders across your campus. So some important considerations for the triage assessment tool. Students and other stakeholders will need time to get used to this new model. Absolutely, they won't love doing a 15 to 30 minute. Students are coming in expecting to see you for an hour, and so it's a big change. And when we say, well, it looks like things are okay, here's what I'm going to tell you to do in the meanwhile so we can get you an appointment, they may not feel heard, or they may feel frustrated, or they may not have time to actually do a 15 to 30 minute tool because they're in between class and they just wanted to see somebody right away. You sometimes will have frequent flyers, I know, who come in to see people often to talk and are they being assessed each and every time they come in? Some places, yes, every single time you come in, you do the 15 to 30 minute screener because your life is transient and your stresses are different all the time. Some places have decided, no, we understand that, Jim is always feeling like he needs to talk to his counselor, and he doesn't need to do the assessment tool all the way. Some of the feedback that we've heard when we implement, triage assessment tools is, some service providers saying, like, if I have a student who's coming and I know that they just want to talk about life, they just want to talk about their wellness, I don't feel appropriate asking them about suicide, or if they use medication, or if they're doing drugs and alcohol. And it's the balance between making those things feel okay to ask and knowing that a young person, doesn't necessarily want to share that because they're just here to get some general support. So needing to decide that as a campus, do we always ask if we know that the student is just coming in to receive help for general life? Because they do that. Do we ask all these questions? I said earlier, it's not always easy to determine where screening ends and assessment begins. So if you start talking to a young person and then it starts unfolding, and then what do? You're trying to do a more comprehensive kind of understanding of his or her issues or concerns. It's hard to shut that down sometimes in 30 minutes, right? Because we're used to having that hour. And that just takes time and practice. And sometimes that initial 15 to 30 minutes turns into a 1 hour. We don't want it to do that all the time. But if someone's in crisis, you got to deal with that. You got to make sure that they're okay. And if it takes an hour to get there, then you take that hour. Letting go of the longer process and embracing a shorter assessment is a big change. I've heard it consistently over time. People feel comfortable in having that 1 hour time slot to figure it out. And when you take that away, there can be a lot of uncertainty. So scheduling within the triage system is probably one of the most difficult things that I've seen campuses try to figure out, as well as communities try to figure out. When you start integrating services and you're co-located and you have a finite number of staff, how many triage appointment slots will you have available per week where when people walk in, they can access service? And how many per day are you going to have? That is something that needs to be figured out and sorted out, because you need to have those available in order for the model to work. Are you going to include emergency hour slots daily and other clinician schedules so that triage clinicians can have adequate resources to respond to emergent situations? So sometimes you have a big enough complement where not everybody is part of the triage sort of team, where other clinicians are seeing people on an appointment base when they were booked in. And so you need to think about, are other clinicians going to be having open spots on their schedule should you have this overflow where you need to deal with everybody? And I mentioned this earlier, but who is responsible for that follow-up if a client who is triaged does not show up? Triage clinician, follow-up clinician, these are some of the things that we've heard about that campuses struggle with, because they're not always sure, who's the owner of that student. Was it the person who did the 15 to 30 minute assessment, or was it the one who was booked in to see that student later? A couple things before we open up to talk for questions. I really wanted to talk about step care approach to service because it is a fundamental part of developing a clinical triage model. For those of you unfamiliar with this approach, it's about a system of delivering and monitoring mental health treatment so that the most effective yet least resource-intensive treatment is delivered first, only stepping up to more intensive services as required and depending on the level of client distress or need. It's been shown to be as effective as traditional care, but it definitely improves efficiency because we don't often always need to book students in for hour appointments to see counselors or therapists or psychiatrists when we can determine earlier on that their level of need is much less and we actually have resources in place to deal with those much less needs. And that's one of the challenges is that many universities have more of the higher intensity services, but some of the, the tier 1 services that could be very helpful are only offered occasionally, your workshops, your groups, and all those pieces. They're not offered all the time. And so students oftentimes miss out on some of those lower level intensity services that are a really important part of this model. And the step care approach to service on campuses, it's founded on kind of some of the following benefits, which is something that, your model has to really think about and believe in, is that people should not have to wait for psychological services if they actually need services so that they can access service right away. And definitely, different people will require different levels of care. You know that, and that's what the triage model will allow you to do. And finding the right level of care depends on monitoring outcomes. So we don't have time today, although I have some slides around quality improvement and evaluating how you're doing in this. But it absolutely requires you to assess reliably risk and then to look at some of those outcomes on an ongoing basis, whether it's wait times, whether it's no-show appointments, whether it's the psychological distress of people, whether it's satisfaction, to really understand that you're actually moving in the right direction with the model. And moving from lower to higher levels of care based on client outcomes increases effectiveness and lowers your costs overall because, we're going to start placing people in the right kind of place for service, and that becomes more efficient, and it's going to actually help clinicians' caseloads over time. It's going to feel stressful at first, but it certainly dissipates over time. So I touched on that. I want to say one thing about governance and reporting structures because this has come up in a couple of times, is that we typically, when we're talking about the integration of services on campus and implementing a clinical triage model, sometimes we're talking about bringing different departments together or different providers who actually report to different, VPs or associate VPs or directors. And so you really need to think about how that's going to impact, and maybe, as a provider, that's not your job to think about, but it certainly is a job of administrators, and it's a job for that model to actually work. You can't have a triage team with providers on it that report to different directors. Like, that just doesn't work. At least in my experience, I haven't seen that work, is that you have to have governance and reporting structures all in the same area. So I am going to stop right there, and I can share more stuff about quality improvement and evaluation, but I want to absolutely leave time for questions. I see a couple things here. Can you email the slides? Absolutely. Can you share some triage tools? Yes, I can absolutely do that. I will give them to CICMH, and they will send it to everybody who logged in. I actually, we did a little activity like maybe 6 months ago where we sent an email to every college and university campus in Ontario, CICMH did, and said, what tools are you using, and please send them. And so I think some people did actually send them through. So we're trying to collect a battery of triage tools so that all campuses can have examples of it. Everybody kind of fixes it according to their own needs. But if we can get, a standardization in quotation marks as much as possible, I think that's going to help all of our campuses. And, then we're going to have a better understanding of Ontario students in general when we do that. Is clinical triage done by nurses or other providers? Thank you for that question, Gaia. It's absolutely done by a variety of providers. It doesn't just have to be nurses at all. It can be counselors, therapists, multiple people. And it should be people that are trained in mental health and wellness and health, for sure. Tracy Robinson is asking, are the wellness coaches part of the solution? I see they are used in Durham College. I think wellness coaches are an absolutely part of the solution. They do mental health work as a function of being a wellness coach, no question about that. But they are, you know, on part of the spectrum of care, a lower intensity service where they can be provided with students, you know, to access some help and support about their overall well-being. And so they are a really integral part of that model in the step care approach, because they can be accessed by a number of students to be able to help their overall well-being, and not necessarily, you know, diagnosable conditions, although of course you're going to end up with students in your office as a wellness coach with that. But then in their new model now, they can refer more easily to other providers who can deal with that. So Bonnie has asked what other universities and colleges have undergone this change in the system, so we can connect further. So I know Western University has been working on this. I know that Memorial University is doing this. I know that Durham College is doing this. And if you just excuse me for a second, I have this written somewhere. I think I do. No. And there's a couple other colleges in Ontario. That I can remember. But we can get back to you on that, because we have that written down somewhere, because we have been working or hearing about what the work of other people are doing. So Bethany says at the University of Guelph, we recently implemented a similar model. Seneca is working on it. Yeah, and I've done some work with George Brown, and they have tried to do a triage model as well. So I think everybody's moving in the right direction. I think that campuses could use a tremendous amount of support in moving in this right direction and leaning on each other about lessons learned and what worked and what didn't work. The college is working on it. Any suggestions if there are only 2 therapists? Okay, so that would be really difficult in developing a full kind of clinical triage model, because I don't know how it works right now. And Perlin, I don't know if people can actually talk if we unmute them, but it might be helpful to hear. Because if you are seeing somebody, if you're the person at the desk, and you're doing a 15 to 20-minute assessment, then you only have one therapist who's actually doing all the work. And then sometimes both of you will be busy at the same time. I think as 2 therapists, you absolutely could use standardized tools to assess young people in your appointments, because then it may not need the whole hour, but it's going to be very difficult in building a triage model just based on 2 people. McMaster University, great. U of T actually does too. How can I forget U of T? How about the use of apps for triaging? I don't have any experience on the use of apps for triaging, and the schools that I've worked with haven't embraced that yet. I think that it sort of comes a bit later in the model development, because there's so much to consider at first, but they kind of want to get it, you know, functioning in some way first before they consider any technological piece. Most of them have used a person to triage But I know what you're saying, where you can go online and you're asked a number of questions and that will determine triage. People feel kind of uncomfortable still with that. The US is using that, and I've read about some of their apps for triaging. It just really kind of depends, I think, on the comfort level of the university to be able to do that. Do you have any ideas on how this centralized triage could work within a peer-peer program where students can help other students before they can see a counselor? Absolutely. So, well, I'm not sure how your peer-peer program works, but oftentimes, and this is when I said, you know, it has to be a mental health provider doing the assessment. It doesn't always have to be. Sometimes we can train other people to do that, because if you're using a screener can be delivered by non-trained therapists. They are intended to be delivered by non-trained therapists. An assessment, on the other hand, has to be somebody who has training in that. But I have seen, and I haven't seen this on campuses, although Durham has a little bit of this going on, is that they do have a peer support worker who is there when the young person arrives and kind of helps them complete the screener, asks any questions, does some of that initial piece, doesn't assess risk and acuity of presentation, of course, but does a lot of the front end work and then is assigned to see somebody who can assess that more accurately. So I can see it working in a number of ways. Oftentimes, like Durham College sometimes actually has a student working at the front desk so that they can leave enough spaces open for screeners and clinicians to actually work. You know, I think we can do a better job with our peer support models on campus, but just being very careful that they are peers and, you know, assessing risk is not their job. Let me just go up for a second. Is triage only for mental health related files, or health more broadly? Mental and physical health are interrelated? Yes, triage is absolutely for all of it. So if you've been able to integrate your health and mental health together, that is what the triage would absolutely be able to do. And oftentimes on the triage tools, there are physical symptom checklists that are part of it to assess that. And so it's not just for mental health related files. For referrals to community resources, a physician referral is required. How is that done in a triage model? Well, I mean, my understanding is that not all community resources need a physician referral, but for those that do, they would have to be booked in to see a physician first. I mean, there are some things that young people can access in the community where they don't always need a referral, but absolutely, if they need a physician, then that has to be booked in. And if you have physician on staff, that's how they would do it. If not, if you don't have a physician on staff, and there are some campuses that absolutely don't, they have a referral to a physician for the young person in the community. So do you have ideas on how to do a triage model with multiple campuses where counselors are only at the campus for a few days at a time? So most campuses have multiple campuses, but I think you probably mean like in maybe different parts of the city. That becomes very tricky. What I have seen is that each campus has their triage model in place. So you can't possibly integrate all health and mental health services in one spot in that instance. And so the triage model would be aligned at all campuses if you're able to do that. If you only have counselors at campus for a few days at a time, then on a Monday when nobody's there, I'm not sure how students would have to go to another campus to access that service. I think you can still have a triage model. It's just not going to be available to everybody at all campuses every day. I think that's the end goal, is to be able to have it always available, but I think you have to just work out how that would work. Do we have cutoff times? So no, I haven't seen that, but there are some campuses, and we have it on the CICMH website, actually. I've seen it where they have, you know, red, green, and yellow, where red, and they have all these indicators of what they consider sort of, here's triage right away, here's what they need. It's not really a score, but here are all the presentation of concerns. These are the yellow folks, and these are the green folks, and it very much operates like that, and they have it laminated at the front so that they can have a really good understanding. So, and then they say 24 hours, 72 hours, you know, within a week and things like that. So there are some examples of that, but I wouldn't say there's any standardization in any cutoff times in taking triage. Oftentimes my recommendation to campuses is it's really what, A, they have the capacity to do. If you've only got 2 therapists, as we've heard, like your capacity is going to be different. And B, it's also what, you know, what you determine as needing kind of, you know, immediate care, and what your practice is around that, and what else is available for students if you can't do that. So I think, you know, that's partly why we haven't been able to standardize that very much, because it's not like going to the emergency room where it's sometimes a bit more clear cut than that. But we'll be happy to share some of those resources that CICMH has actually collected already around some of those cutoffs. Catherine, it's a great question, and one that some campuses are thinking very carefully around. So they're working very closely with their international department to help develop the model, to understand what students who come from different countries internationally, what would best suit them in this model and how that works. They've also included those international students in some of those discussions around the development of the model. And so, you know, would it look differently? You know, I don't think it looks differently. I think sometimes the assessment of mental health and risk obviously is different cross-culturally, as we know. The space that you create might be different in terms of making young people feel comfortable. The model as it sits wouldn't necessarily look differently, but having international students and other marginalized groups inform the development of that model is something that people are taking very seriously, and know that they have to include those to ensure that it makes sense for them. How do campuses deal with evenings and weekends when university hours are closed? So one way they have done it is partnerships with community agencies in their community who are willing to offer like crisis support on campus. So it's a partnership. For example, Western has a partnership with CMHA in London, and they come in and have crisis support at really stressful times of the year for students after hours. Durham College is offering after hours care up until 7:30. I don't know if they do this every night, I can't remember, but they were doing that. So people are just trying to find ways to actually have that available for students. You know, having a better electronic presence online, so students are very clear about what they can access in the community when the university is closed, is really important. So the online presence of most mental health websites, unless you've had a strategic plan in place, is pretty messy and very hard to navigate. But that has to be really, really good in place for students who are accessing help after hours. And a lot of the residences on colleges and university campuses do have after hours at least support with residence dons or other residence counselors who are there in the evenings.
Okay, then that's probably all the questions that we have time for, because now it's 2 p.m. But it's really very, very popular topic, lots of interest. And I was talking to Debbie earlier, and if people are interested in maybe having a part 2, please speak up, and we'd be happy to kind of discuss this in more detail as well in the future, because there's so much to the model that there's not much that can be covered in an hour. Yeah, see, already some interest. I just want to quickly jump in and speak to that last point that Debbie was talking about having some partnerships with your local community organizations. If people are interested in that sort of thing and you're looking for resources on MOUs and that kind of thing, please reach out to me. We're happy to share that as well as any of the assessment tools and such that Debbie mentioned. With that, I just want to give a big thank you to Debbie for sharing the work that you're doing. Look, we have lots of comments rolling in saying yes, please, the part 2. So it looks like we've got lots of interest. And thank you to everyone for joining us on this great webinar. When I close the meeting, a short survey is going to pop up for you to share your thoughts and any sort of comments about the webinar. So please feel free to fill that in. Any last thoughts, Debbie?
No, thank you so very much. And maybe we can get a sense for part 2. I think we should look at some assessment tools. Everybody always has that, and sort of triage levels and things like that. And then maybe hearing from some people who have started to do this as being part of that would be really great.
That would be amazing. So stay tuned, folks, and hopefully there'll be a part 2. All right. Thank you, everyone. And thank you, everyone. And have a great rest of the day.
And you can also reach out to me anytime. So Carolyn will send you my email. So please just reach out if you have questions or need anything specifically.
Wonderful. Well. Thanks, Debbie. So follow-up email is going to go out to everyone who was registered on the webinar, and that will have the slides as well as a recording of the webinar and Debbie's email. So again, thanks very much, everyone. Have a great day.